Hello everyone, how are you all? Welcome everyone to First Aid AMC MCQ again. So how is our 2 weeks free session is going on so far? Are you guys enjoying our session? Good. So tonight we are going to finish cardiology, not totally finishing, I would say, but we are going to finish the most of it, right? Because we are still left with the ECG, but apart from ECG, everything is good. So we are finishing the cardiology tonight, and we will finish with cardiology question solvation. Now, question solvation is a whole new thing, as you have already known. We have taken another question solvation class previously as well. Now, for those of you who are very new to this MCQ preparation, for you, I will say that it will be a little difficult today to grab everything because the questions that we are going to solve, sometimes it's not fully complete questions, just like your exam. Sometimes we might just get a little information, or even we might not get total information to answer that question properly. So, but still we will touch that because the most important thing to learn from question solvation is how you're going to improve your theory so that you can answer anything related to this topic. Okay, it's not like you are going to memorize a lot of questions and then in the exam you will get all these questions. It's not something like that, and whoever talking in that way, they are not in the correct guideline actually. So it's something like you get to solve a lot of questions and you get an idea about the questions pattern and everything, and then you will understand that how in the exam you will implement your theory knowledge to solve particular questions. That means from this question solvation, you will understand what are the important topics are there and how we get to one particular answer out of five. Very easily you can get like tricked with the five options because most of them are very close to each other. Okay, so how we can find out the correct answer from very close options, that's how you understand from question solvation. Never ever memorize answers of any questions because that's not an appropriate thing to do. And also a lot of candidate has failed previously just for doing those sort of things. And I would say that if you have a very good theory knowledge, then there is no questions that you will not be able to answer. Okay, and in the exam you don't need to get the everything correct, right? So out of 500 mark, if you get 250, you will pass the exam, and you just need to pass the exam. So that's important. So to pass the exam, you need to have a good theory knowledge and you implement those knowledge on your questions. So tonight we're going to work on that. So this is your first question. A 12-year-old male was running a race and suddenly collapses on the floor. Luckily, someone was there and performed CPR as patient did not have a pulse and resuscitated him. Upon arrival to the emergency department, it is revealed that his father died at the age of 28. Very important clue. So early cardiac death in the family, right? He is now alert, asymptomatic. ECG was non-eventful, and he is anxious to go home. What would you do next? So first of all, what is the age of our patient? 17-year-old. So teenage or young adult patient was running a race and suddenly collapses. So that's one of the syncopal attack he had, right? And also it was a very serious one because as you can see that this patient need to had a CPR also at that time. Someone's video is on. Please do not open your video. I'll just stop it by myself. Okay. So what we have been discussing about, so 17-year-old had a syncopal attack and family history of sudden cardiac death. ECG is non-eventful, right? So what do you want to do next? And what is your most likely diagnosis? Now, a couple of things can happen in here. It could be any arrhythmia, right? So it could be a case of Hookham, as I can see a lot of you has written in here in the chat box. So what else can be? 17-year-old had a sudden collapse and with a family history of sudden cardiac death. What else apart from Hookham can it be? Yes, very good, Dr. Saida. Prolonged QT syndrome, like a congenital prolonged QT syndrome can be another possibility. So if it was a prolonged QT syndrome, in the ECG, you would get that. So if ECG is non-eventful, most likely it's not a prolonged QT syndrome. So most likely it's Hookham. All right. So can you send that patient home? Or what do you want to do? You want to send him home and arrange an outpatient consult? You want to send him home without doing anything? You want to admit and refer to cardiologist, outpatient echo, stress echo. The first thing that you need to do, you need to admit that patient. Now, yes, this is where, see that the options in here, this patient will eventually need a stress echo or just a resting echo first. But before doing a stress echo is usually that what you don't usually do that. Cardiologists are supposed to do that or arrange that. So the first thing you can do is to admit this patient and then refer for cardiologist team consult. Cardiologist will come and then cardiologist might want to do a normal resting echo first. If resting echo is also good, then even after that, if the cardiologist is suspicious, then he can arrange a stress echo. Okay, so that's the last option. So if they're asking what would you do next, this is the important part. The next thing that we are going to do is to admit this patient and then refer for a cardiologist team consultation. Okay, so this is our answer. Cool. Next, a young athlete presents with history of sudden syncope and dyspnea. So syncope means loss of consciousness. As we discussed a little bit, we'll discuss more tonight. So young athlete presents with history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had a sudden death at a very young age. What is your initial treatment? Now, I understand that you should think about Hookham at this time also, right? So young patient, sudden syncope, and ECG showing left ventricular hypertrophy. What do you want to think about? You think about Hookham immediately. Now, for a Hookham patient, what is your initial treatment? So you want to do verapamil, septal myomectomy, defibrillator, low molecular weight heparin, adenosine. So remember, either beta blocker or calcium channel blocker will be our initial choice of treatment. Okay, so that's our treatment in here. Very good. You guys are doing really good, really great. That means you remember what we have discussed. Right? So these are the treatment, beta blocker or calcium channel blocker. We don't give these drugs, no digitalis, no diuretics, vasodilators, or exercise. Okay. Just hang on a second. I think I missed. Give me 1 second. I think some of the answers are already given. Okay, give me 1 minute. I'll just get rid of that so that you guys can answer it properly. Hang on a second, guys. Sorry for it. I think I removed that. How come it came here again? Hang on a second, guys. Okay. I can see someone's screen in here. Is there anyone of you who is sharing it? Please don't share these things. Okay. All right, let's move on. So we discussed this one. The next one. So you got a young girl, 15-year-old, collapsed at exercise. Her father had hook'em. And after ECG and echo, you found no abnormality. What is your next step in this patient? So obviously you guys should know that what would be the answer. So if we're thinking about hook'em and we did a ECG and the echo, there is no abnormality. When we know that father had a hook'em, we should obviously confirm that by doing a stress echocardiogram. So nothing else. So we don't need to repeat this echo again because it will not give us any information. So if the resting echo is normal, we will go for a stress echocardiogram. Now, similar questions. I'm showing you that how, from a single topic, what are the ways a question can appear in your exam. So knowing the theory is very important. That's what I'm trying to show you today. A 9-year-old male person was playing football. So it's 9-year-old male, no? Should be 9-year-old boy running, playing football, and suddenly collapsed on the floor. Upon arrival to the ED, it is revealed that his father died at the age of 28. He is now alert, asymptomatic. What would you do next? Now, your question is, what do you want to do next in this patient? So you're thinking about a 9-year-old boy who had a collapse while playing football. So their question is, what do you want to do next? You want to do a Holter, a stress echo, repeat echo after 3 years, ECG, or a echocardiogram first. So remember, always if they ask next means what is your initial investigation? That means you should always start with the ECG. Very good. You guys are getting what I'm trying to say. That's really, really good. So let's move on. All the hook'em questions are gone. Now, another topic, murmur. So a 16-year-old male who presents with ejection systolic murmur. So it's an ejection systolic murmur in second left intercostal space. It's a 16-year-old. Which of the following is likely to be the diagnosis? Now, unfortunately, we haven't discussed ASD so far because we discussed ASD, VSD in pediatrics cardiology. That's why I haven't discussed it yet. But let's discuss it because we got a question. So 16-year-old having an ejection systolic murmur in the second left intercostal space. Remember I told you about this intercostal space thing? Tell me one thing, in the second, this is second left intercostal. This is second right, okay? So in the second left intercostal, what you get usually, pulmonary or aortic? In the second left, what you get normally, pulmonary murmurs or aortic murmurs? Pulmonary murmurs, right? Remember it? So we discussed about this one, that why we get pulmonary murmurs in the second left intercostal space. Now, if you just remember that point, you will get the answer. Okay. Now look at here. couple of other information is given that it's a ejection systolic murmur. That means now you need to know that what causes ejection systolic murmur. The important thing is all the options has ASD. That means this patient obviously having ASD, right? There is no way this patient can't have ASD because all the options are there. So this ASD is actually causing this ejection systolic murmur in the second left intercostal space. Now, sometimes ASD can cause complication. So that's what they're wanting to find out. So is it ASD with aortic stenosis, ASD with mitral stenosis, ASD with aortic regurgitation, or pulmonary hypertension? You guys are right. It's C, pulmonary hypertension. Why? So remember this beautiful picture that I used to draw with you, although it's not very beautiful. So this one in here, if you look, if someone develops ASD, that means atrial septal defect, right? So this is your left atrium, this is the right atrium. And let's say this is your pulmonary artery. And that's your pulmonary valve, right? Now, if someone develops this septal defect, what happens? Blood usually will come from high turbulence to the low turbulence. Always the left side has high turbulence normally. So blood will come from here, from the left atrium to right atrium. So lots of blood is coming. So in the right atrium, blood from inferior vena cava is coming, superior vena cava is coming, and now also from left atrium, some blood are coming to the right atrium. So lots of blood volume in this area. So what it will do, it will send the blood to the right ventricle, and eventually a lot of blood will also flow towards pulmonary artery. And what it will cause? It will cause pulmonary hypertension. Okay, so this is the pathophysiology. Now, if we go through this murmur of ASD, it has a very good guideline in the med bullets. If you go through the med bullet, this guideline you should get. So always go through this one. Let's have a look if we can find something. So we already know what is atrial septal defect. It's a defect in the septum which separates the two atrium, right? See this one, systolic ejection murmur along the left upper sternal border. So this is your answer. There is another question very commonly make candidate confused, that they give ASD, VSD, and also Fallot's tetralogy, a lot of options. And sometimes they can give you like two types of murmur, like a patient having some shortness of breath on exertion, and it's a young patient, like even a child, 8 or 9-year-old. And once you auscultated the precordium, you found that that child is having ejection systolic murmur along with a diastolic rumble. So if you get this ejection systolic murmur with a diastolic rumble, always think about ASD, especially in young, like in children, or especially in any young adult. Okay, so that's one of the important findings that you also will get in ASD. Usually two types of murmur can be found. So that's one thing. And the most common form of congenital valvular defect is VSD, which is the ventricular septal defect. In VSD, you get pansystolic murmur in the right sternal border. So you need to remember this ASD, VSD murmur because a lot of questions come from here also. So VSD will give you pansystolic murmur in the right sternal border. Okay. Sometimes it can, like usually along the sternal border, you will get a pansystolic murmur, which is quite loud and harsh. That's VSD. Whereas in ASD, you get two types of murmur. Okay. And right now you also know that how ASD causes pulmonary hypertension. So this is your answer in here. 16-year-old having an ejection systolic murmur in the second left intercostal space. Why it's not anything else? Because aortic stenosis will give you one type of murmur. Mitral stenosis would give you another murmur. Aortic regurgitation would give you another murmur. So these sort of things should be there. So if someone having ASD with another valvular defect, at least you should get a 2 type of murmur. Okay, but in here only ejection systolic murmur you can get. And why it's not aortic stenosis? Aortic stenosis also give ejection systolic murmur, but it keeps in the right side, not in the left side. Okay, so remember all these informations, and this will help you to get your answer properly in the exam. Let's move on to the next one, right? So a young guy, while playing cricket, suddenly had a syncopal attack without any convulsive features. Soon he spontaneously recovered and started fielding, continue playing the rest of the game. What is the cause? Now, remember I told you we'll discuss syncope through questions tonight. So what is syncope? Syncope means loss of consciousness, which can be due to a lot of reasons. So normally you should think about cardiac syncope, neurogenic syncope, and also vasovagal syncope. There is a lot of other syncope related to position, like someone going for a micturition or urination and they had a syncope. That's a micturition syncope. Someone having a lot of coughing and then they lost consciousness. That's a cough syncope. So there is a lot of syncope, but the important one that you remember is vasovagal syncope, cardiac syncope, and neurogenic syncope. The most important differentiating factor between a cardiogenic syncope and a vasovagal syncope, because someone who is playing, they tend to get any of these two. Either vasovagal, it can be due to like someone playing in a hot sunny weather and they can develop a vasovagal syncope. What is vasovagal syncope? Usually when you are standing for a prolonged period of time, or you are overexerting yourself, or you are like doing a lot of exertion, playing, exercise in a hot sunny weather, sometimes your vagal nerve can get stimulated. And it causes peripheral vasodilation, which means there will be a peripheral pooling of blood in your lower legs and extremities. So if there is a lot of blood getting accumulated in the extremities, your heart is not getting enough blood, right? So venous return is reduced. If your heart is not getting enough blood, heart is unable to pump blood to the whole body. And most importantly, your brain will not get enough blood and oxygen supply that time. And that will lead to this syncopal attack. Patient with vasovagal syncope, they get a prodromal sign first, like they feel lightheadedness, dizziness, and sometimes even they start sweating. Okay, so that means they know that they are going to fall. And they remember these symptoms after getting the consciousness back. So always, if you're thinking about vasovagal syncope, these are the important things that should be there in the question. But on the other hand, your cardiogenic syncope, it doesn't give any prodromal symptom. It happens very suddenly. Patient doesn't even know that they had a fall and they lost consciousness. And then they regain consciousness within few seconds to minutes. And when they regain consciousness, they don't have like any confusion, no dizziness, no other symptoms. They start doing the work they were doing before the syncope, just like before. So this patient, if you look at here, you can see that there was a sudden loss of consciousness, and then he regained consciousness and continued playing rest of the game. So what do you think this patient is having? Vasovagal, cardiogenic, epilepsy. So we don't think about epilepsy because in the question is already said without any convulsive feature. So not epilepsy. Okay. Neurogenic syncope can be, but this patient doesn't give any other feature. So we'll discuss about neurogenic syncope after, like maybe after the break. So hang on to this one. Okay. Postural hypertension. Always in the option you will get, or in the stem you will get, patient get dizzy or lightheadedness when they change their position, like maybe from lying to sitting or sitting to standing. So when they change their position, they get lightheadedness. They might even fall or even lost their consciousness. So that's postural hypertension, which is not in this patient case. And vasovagal, no prodromal feature, so unlikely. So this is our cardiogenic syncope or cardiac syncope. Cool. Any question? So if you look at here, you can see if there is post-ictal state, then we think it as a seizure or convulsion. Otherwise, it's syncope. If there is prodromal sign, then we go for vasovagal. If no prodromal sign and recover immediately, that means within seconds, more with cardiogenic. Okay. But sometimes it could be neurogenic also. In neurogenic, they also don't get any, like they might not get any prodromal features. Sometimes they might get, that doesn't matter, but they will get sudden syncope and they will come back in minutes, not in second like cardiogenic. Vasovagal syncope is one type of neurogenic syncope also, because in here the vagal nerve gets stimulated. Okay. There is a very good discussion about this syncope in this guideline. So please go through this guideline at your own time. So that's our answer in here. Next, a 45-year-old male presented to the emergency department with left-sided chest pain radiating to the left arm and jaw. So we got chest pain now. There is no ECG changes. So no ECG change. Troponin is negative 4 hours since the onset of chest pain. He has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? So this is the important part, next treatment. So you got a 45-year-old with a left-sided chest pain radiating to the left arm and jaw, no ECG change or troponin after 4 hours of onset of chest pain. Right? So what do you want to give to this patient? That means this patient is still having chest pain. Okay, they haven't said that patient is pain-free or something like that. But there, as we understand, there is no ECG change or troponin change. Now, again, we can't just say that it's not myocardial infarction because we need to do a repeat ECG and a repeat troponin before we say that. It can be a possibility of MI still now. Now, what do you want to do in here? They're asking the next treatment. So you want to go for nitrate, heparin, morphine, beta blocker, paracetamol. For something which is cardiac related, paracetamol will not be your choice of painkiller. Beta blocker usually given like in a stable angina or maybe some like after a few days of treating myocardial infarction, not initially. Nitrate is a choice in here, but you don't give nitrate to someone who is on sildenafil. Okay, so contraindicated. Then you have heparin and morphine. Heparin only indicated if you would find out that this patient having non-ST elevated MI or even like ST elevated MI. So it should be MI in the question diagnosed, then you can give heparin. So again, not a possibility. So what is your option left? Morphine, right? So you can give morphine in here. So understanding the question is very important. Otherwise, you might end up choosing nitrite if you don't know that sildenafil thing. Okay, you might even go for heparin, but heparin only indicated if you know that this is a MI patient. Then otherwise, no need to start heparin to every patient. No, in unstable angina, we don't need to give heparin. Okay, so injection we are giving as a blood thinners. It's only given if someone having a documented thrombosis, either non-ST elevated MI or ST elevated MI. You can give beta blocker, but not the initial or next management in here. Okay, because beta blocker is not like, it is not going to help at this moment. Beta blocker is indicated like after a few days, once this patient will be diagnosed with like, let's say unstable angina or MI, they will be treated accordingly. Once that patient becomes stable, then you start the patient with ACE inhibitor, beta blockers, those medications. Like that means usually 1 to 2 days later. That's not immediately. Okay, But if this patient is diagnosed with a unstable angina, then you can start beta blocker. Right now, you don't know anything, and this patient having chest pain. So what is your first thing that you would do? You would try to make sure the patient becomes pain-free, okay? If there was an option of aspirin, we should obviously choose that, okay? There is no way we would choose morphine before aspirin. So if there was an aspirin in the option, we would obviously choose that one. But as that is not in the option, what is our next best option in here? Morphine. Clear? A 72-year-old male presented with severe chest pain, radiating to his back. On cardiac examination, you notice diastolic murmur. Chest X-ray shows wide mediastinum. So that's your clue to the diagnosis. Severe chest pain, 72-year-old, radiating to the back. Which chest pain radiate to the back? Okay, and you got X-ray finding. So what is your diagnosis? Now you haven't looked into the ECG. Let's look into the ECG also. So by the look of it, it looks like aortic dissection, right? Now let's look at the ECG also. What is your, so now ECG we haven't discussed, so it will be very complicated for you, I understand. Let's just touch the point, okay? So that once we will start discussing ECG, you will get to understand everything very quickly. Now in the ECG, we look for V1 to V6. These are your chest lead. And then you have 6 limb lead also, which is lead 1, lead 2, 3, AVR, AVL, AVF. If anytime you get chest pain patient, you look at the chest lead first, followed by limb leads. So in the chest lead, what you are looking for? You're looking for either ST elevation, ST depression, okay, or you're looking for T inversion. For ST elevated AMI, the name says what you're looking for. You're looking for ST elevation. Okay, what is the ST? If you don't know where is the ST, then it becomes really hard, right? So now let's look at here. First of all, you need to locate where is the isoelectric line. Sometimes it becomes difficult in this sort of ECG. Isoelectric line is, these are the isoelectric lines. See this one? A normal patient's, this is the P wave, okay? And that, oh, sorry, this is not P wave. This is actually the T wave from the previous one. So this should be the P wave, then QRS, and this is the T wave, okay? So this is isoelectric line. And this one, as you can see, this is your ST. A normal person, ST should be in the isoelectric line. But if you get this ST coming not here, okay, rather than here, it becomes ST elevation. Look at lead 2. Where is the isoelectric line? This is your isoelectric line, right? So where in here, there should be the ST. Now see, where is the ST in here? So that's your ST elevation, okay? So you have got ST elevation in the lead 2. Lead 2, 3 AVF, these are called inferior MI leads. So always look these 3 lead at the same time. So look at lead 3. This is isoelectric line. So where is your ST? In here. Look at lead AVF. Where is your ST? In here. So these are all ST elevations. So you got ST elevation in lead 2, 3 AVF. Okay. Once you get that, you can immediately think about it's a case of myocardial infarction, like a ST elevated AMI. Okay. So now you got ST elevated AMI along with aortic dissection. Can aortic dissection cause MI? Yes. One of the complications of aortic dissection is myocardial infarction. Okay. So this patient having both AMI and aortic dissection, most likely initially he has got aortic dissection and that has got complicated with the AMI. So what's your treatment for this patient. So you want to go for thrombolysis, alteplase. You want to give aspirin and intravenous morphine. So they're asking the most appropriate, okay? Give morphine, beta blocker, and arrange for transesophageal echocardiogram. Refer the patient to cardiology clinic. Consider urgent MRI of the cervical and thoracic spine. This is not the most likely reason. Now, you just don't refer a patient, you need to do something for this patient. If you refer the patient to a cardiology clinic, who knows when this patient will go there, okay? So if there is an admit in the cardiology clinic, that's one of the options, but that's not in here. Referring and admission is different. So can you give thrombolytics in here? How about giving thrombolytics in this patient? No, why not? Because if you give thrombolytics in a patient of aortic dissection, that patient is going to die. Okay, so contraindication. Remember the contraindication, aortic dissection, suspected aortic aneurysm or aortic dissection. That's a contraindication of giving thrombolytics. Now you have B and C option. So aspirin and intravenous morphine. This might help you with the MI. What about the aortic dissection you have got? What you are going to do about that? And they're asking you the most appropriate management. The most appropriate management, see that it would be a good idea in the option C if we would get morphine, aspirin, beta blocker, and others. So that would be a good idea. But we haven't got that, unfortunately. And we need to know that if it is a case of aortic dissection or not, and what type of aortic dissection it is. So the best option for this patient among B and C would be giving morphine, beta blocker, and arrange for a transesophageal echocardiogram. Okay, always in the question, sometimes you might not get most appropriate things, right? But you have to choose. When you come to that point, obviously we would give aspirin sometimes, but for someone who is having an aortic dissection, giving anything which can cause like bleeding, usually it's better not to give it. Like aspirin can increase the bleeding, heparin can increase the bleeding. So it's a very complicated thing in these cases. So we try not to give anything because the underlying reason of having the MI is the aortic dissection. And we need to treat that. If we can treat that, MI will get better. So the most appropriate option will be this. Patient having chest pain, give morphine. Now, okay, if this patient is having aortic dissection, we can start with beta blocker. That's fine. And then arrange for a transesophageal echocardiogram. Among these B and C, C is better option. Okay, that's right. Because if you're choosing B, you are not thinking about aortic dissection at all. So this is your widening of the mediastinum. You can see in the aortic dissection. Next question. So you have got an elderly patient having a multiple fall during the day, especially in the morning after waking up. ECG found left ventricular hypertrophy and multiple ventricular ectopics. Orthostatic hypotension was also noted. Orthostatic and postural hypertension is same. How will you investigate further? So this patient having multiple falls, it's an elderly patient. Fall can happen due to a lot of reasons, can be cardiological, can be cardiogenic, can be neurogenic, and a lot of other reasons. One of the reasons is postural hypertension also. So we have got some finding in the ECG. We have got some finding in the blood pressure also. For this patient, what would you do next, or how would you investigate this patient further? You want to do a repeat measure of blood pressure in supine and prone position, 24-hour Holter, serum electrolyte. Serum electrolyte is not important in here because we haven't got any vomiting or diarrhea in here. If we would get something like that, we could choose that. Now, if this patient having postural hypertension, we should always confirm that. And we confirm it by doing a repeat measure of blood pressure in sitting and standing position. Now, if you check it in supine and prone position, what will happen? Patient will be lying, right? So both supine and prone, patient is lying. How it will give you the postural hypertension? So if in here there was an option of doing a repeated measure of blood pressure in sitting and standing position, we would choose that because that's the next appropriate things to do. Because sometimes just a postural hypertension can be a possibility of having multiple fall. Okay. Now, as this is not a correct option in here, the best option would be doing a ECG halter, because sometimes in the ECG halter, we might end up getting more cardiac arrhythmia, right? So it may not be just a ventricular ectopics. Maybe this patient having underlying heart block, okay, or something else that might cause this fall as well. So it's a good idea always to do a halter monitoring for this sort of patient. Remember what is the halter job? Halter detects any underlying arrhythmia in a patient. Okay, so we can look for that in here also. So this is your syncope. Loss of consciousness can be sudden or gradual. If it becomes gradual, we think about metabolic, like it could be hypoglycemia. Sudden is mainly either cardiogenic or neurological. Depending on the regaining of consciousness, we think about either cardiac or neurologic. If it is sudden regaining of consciousness, cardiac, gradual regaining, think about neurological. Neurological, most likely we are thinking about seizure or convulsion. Okay, next, a young patient has been getting multiple lightheadedness and dizziness. His clinical features are normal. Chest X-ray, ECG normal. Holter monitor shows ventricular ectopics. Whenever you get something in the ECG or Holter, look at the patient. Is it a young patient or elderly patient? Because elderly patients are high risk. Young patient is not high risk most of the time. What will you do next? You will reassure the patient. You will do exercise tolerance test, dobutamine-induced echo, or plain echocardiogram. So these patients, there is no clinical features other than having a multiple lightheadedness and dizziness. Chest X-ray ECG normal, and Holter showing only ventricular ectopics. Look at ventricular ectopics in your JM. Most of the time asymptomatic. Some of the drugs like digoxin and sympathomimetics can lead to ventricular ectopics. If it's an elderly or middle-aged patient, we should look for ischemic heart disease, mitral valve prolapse, thyrotoxicosis, left ventricular failure. If symptomatic but otherwise well, with a normal chest X-ray and a ECG, you can reassure the patient. Look at this one. Now, have a look at this one. Patient is symptomatic, but normal chest X-ray, normal ECG. What you will do? You will reassure the patient. But you should do chest X-ray and ECG before you reassure. Okay? Sometimes if you get a patient like a middle-aged or elderly patient, then you can think about doing an echocardiogram before reassuring the patient. That means if you want to start treatment for ventricular ectopic, like elderly patient, because of ectopic is getting fall. Okay, so you don't want an elderly patient to get a fall, because by having a fall, they can have an intracranial hemorrhage, right? Or even at least a subdural hematoma. So you don't want that to happen in an elderly patient. For them, you can start beta blocker for their symptoms. Before you start treatment, then you should do an echocardiogram. But if you want to reassure, you don't need to do an echocardiogram in a symptomatic patient who is having a normal chest X-ray and a normal ECG. So this patient, you can just reassure. Next question. A patient is on amlodipine, amiodarone, furosemide, aspirin, and having intermittent form. ECG given, which is looked like hyperkalemia ECG. In the hyperkalemia ECG, you will get tall peaked T wave, widening of the QRS complex. Okay, those sort of findings you might get. Now, this is a very controversial questions. I might not be able to give you like exact explanation because none of these options are correct to me. But again, because this is a controversial thing, I would like to just give you like it could be a possibility, a possible answer. Okay, so by exclusion, I can come into that because I have tried to search a lot about this particular drug interaction, but nothing come up. So they're asking about hyperkalemia. So always look at here. So you got furosemide. Furosemide causes hypo or hyper. It causes hypokalemia. So very unlikely that it will cause hyperkalemia. Okay, so you can think less about it. What else? There is another furosemide. So you can think it's not likely the cause. Two options left: amlodipine, amiodarone, aspirin, amlodipine. Now, some of the guidelines say there is a possibility that amiodarone can cause hyperkalemia. It's not very, very commonly, but can happen. So if amiodarone causes hyperkalemia, we can keep this option as a reason of hyperkalemia. I haven't got anything in terms of amlodipine, and also like why and how amiodarone causes hyperkalemia. It's not very well understood, or I haven't found any good explanation in terms of that. Okay, so just keep it in mind if it comes. But next question, let's have a look. This one have a very good explanation. So you've got a scenario of multiple drug. Usually drug combinations are very, very important for exam. You should have a basic idea about some of the common drugs complications like antihypertensives, very commonly asked. So a patient, let's say a 50-year-old patient coming to you with muscle weakness without any tenderness. So patient having muscle weakness but no tenderness. And on questioning, you have got this patient is on ramipril, which is ACE inhibitor, amlodipine, calcium channel, hydrochlorothiazide, celecoxib, which is a NSAID. Okay. Now, the options are these three: ramipril and hydrochlorothiazide, amiloride and ramipril, celecoxib and hydrochlorothiazide. This patient is also on amiloride. Okay. So what do you think? Very easy. Thiazide diuretics causes hypokalemia. Ramipril causes hyperkalemia. ACE inhibitor, right? Hyperkalemia. But if this one causes hyper, this one causes hypo. So it should counteract each other and potassium should be normal. Same with celecoxib and hydrochlorothiazide. This causes hypo and this causes hyper. Okay. Now ramipril, ACE inhibitor, increase potassium. Amiloride, it's a potassium sparing diuretics. So it also increases potassium. Both of them increase potassium. So that's the cause of hyperkalemia. Now, hyperkalemia, can it cause muscle weakness? Yes. Both hypo and hyperkalemia can cause muscle weakness. Okay, so this is how you understand these sort of questions. Next, ECG of an adult patient is given. Patient presented with chest pain. Cardiac enzymes and first ECG is normal. Blood pressure is good. After 8 hours of observation, his blood pressure goes down to 89/50. So that means this patient is hemodynamically unstable. ECG showing SVT, supraventricular tachycardia with a heart rate of 150. What would you do? Now, we haven't discussed this palpitation. So tonight, I'll just give you some touch, okay? Because we'll discuss it again in our ECG class discussion. But we'll discuss some of the treatment of important palpitations tonight as well. For supraventricular tachycardia, it's a very common cause of palpitation. And very common, commonly it occurs in young adult patient. Not only young adult, but sometimes it can happen in a middle-aged or elderly patients also. But commonly young adult without any underlying heart conditions, SVT is the most likely cause. Now, this patient having chest pain, okay, symptomatic patient, and having a SVT, treatment of SVT depends on hemodynamic stability. So it's a supraventricular tachycardia. That means you can see heart rate is very high. Normal heart rate should be below 100, and now it's 150. So this patient having tachycardia. The most important thing when you get like a palpitation related symptoms or ECG finding like a SVT, you look into the blood pressure. So is it a stable patient or unstable patient? This patient is unstable. Any unstable patient, if it's SVT, if it's a atrial fibrillation, if it's a atrial flutter, all these unstable patients will go for DC cardioversion immediately. Okay, that's the only option you will get. If this patient was hemodynamically stable, then there are lots of options we would have. So we could start with just a vagal stimulation. So you could go for Valsalva maneuver. You could go for immersion of the face in cold water. Okay, you can go for carotid massage. So any of the vagal stimulation sometimes can resolve SVT. If that would not work, the next option is medication. What medication we give for SVT? Adenosine. So you can give adenosine. Sometimes if adenosine is not a choice, then you can even go for verapamil. But most of the time, adenosine is the choice of treatment. Even after giving adenosine, patient is not improving, then the last option would be the DC cardioversion or synchronized cardioversion. Okay, but if the patient is unstable, immediately we go for DC or synchronized cardioversion. All right, we'll start with after the break. So let's take a 10-minute break. Do you guys have any questions so far? All good? Okay, let's take a 10-minute break then. Thank you. All right, guys, let's start again. Okay, so next question. The answer will be cardioversion. Okay, who asked it? Dr. Shushmita. Because the patient is unstable, that's why. Okay, so patient is on digoxin, bisoprolol, and thiazides. Long-term history of hypertension and congestive heart failure with AF, atrial fibrillation. Stopped taking medication for 3 weeks while on vacations. Now presents with edema up to his knees and a raised JVP for 4 centimeters, but with clear chest sound. This is a very important clue that many candidates even will not notice. Blood pressure is not that bad. Pulse is irregular. That explains this patient having AF, right? What would you do as an initial management of this patient? So what we have got in here, this is a CCF patient, congestive cardiac failure patient on the background history of hypertension and AF, stopped taking medication for 3 weeks and now come back with the edema up to the knees. JVP is elevated, but no dyspnea, no bile, something like that. So what do you want to do first in this patient? You want to commence furosemide, spironolactone, metoprolol, digoxin, bisoprolol, or recommence all medications. Remember, I talked about this in our discussions. Okay, so in this case, when you have got a CCF patient who is only having edema up to the knees, but the chest is clear, not necessarily you want to start diuretics. Okay, so what you want to do, you just restart all the medications patient stopped without any medical consultation. Okay, so that would help with her all the problem that she is having at the moment. So you don't need to start any new drugs, just recommence all the medication she was taking. But if this patient at the moment was having dyspnea or having bivascular crepitation, that means this patient already developed pulmonary edema. That time you would start with furosemide first. Okay, clear, guys? This is very important to understand. Next, ECG was given showing M spike, excuse me, guys, in the QRS complex in all leads and also in the lead 2. And you have got irregular rhythm. Heart rate is elevated, 150. Patient is hypertensive. Blood pressure is also elevated. Patient is taking only atorvastatin. And no chest pain, nothing else. Now, this is a little complicated or confusing kind of questions. Without having a look at the ECG, it's very tough to say what is this M spike they're talking about. What we can see in here, there are M pattern. So M spike can be there like this. Now, we don't know it's a bundle branch block or not. When we'll be discussing about this, then you guys will understand what is this M spike and everything. But for the moment, just remember, this patient is having irregular rhythm with a heart rate of 150. Just by using these two things, you understand this is a AF patient, right? AF only gives this high heart rate with the irregular rhythm. So you say atrial fibrillation and patient is fine, patient is not unstable. For a atrial fibrillation patient, what is your initial treatment? That's their question, okay? So metoprolol, which is the beta blocker, apixaban, warfarin, verapamil. So our initial treatment will be beta blocker, which is metoprolol. All right. So again, like this is most likely not a case of bundle branch block, because if it was a case of like a left bundle branch block, or it's a new onset left bundle branch block, we would think about ischemic heart disease or even a myocardial infarction. But in the option, nothing like that, right? So option also says that it's not something related with ischemic heart disease or AMI. So most likely they're talking only about AF. Next, a middle-aged man, known hypertensive, started feeling dizziness and he feels his, what is P? Epixaban. Epixaban is a newer oral anticoagulants. Okay. A middle-aged man, known hypertensive, started feeling dizziness and he feels his heart is racing. It occurred after running. There was also travel history few days ago. Very important history, like for someone who is having racing of the heart, palpitation, right, with dizziness. He is on irbesartan and a hydrochlorothiazide and it's well controlled. No mention of diabetes. Blood pressure is all good with no postural change. What is the most appropriate next investigation? Very important question. And sometimes you might get it wrong if you're not careful with reading the question properly. So yes, travel history. For someone who has a travel history, on the top of that, if they present to you with tachycardia, which is racing of the heart, and feeling of dizziness, we should immediately think about pulmonary embolism. Because if it could be a case of ISD or myocardial infarction, but this patient is not having any chest pain, right? So we should not think about it at the moment. So no need to do a troponin for that. And there is, we can think about hyperthyroidism, but that doesn't go with this travel history, feeling dizziness, okay? Hyperthyroidism can cause tachycardia, but not other information that is given. If you think someone having most possibility of pulmonary embolism, we should always go for CTPA rather than doing a D-dimer. Okay, because D-dimer is non-specific. If you suspect someone to have pulmonary embolism, immediately in the Wells criteria, he gets 3 points. Okay, with that, this patient having tachycardia, like heart racing, and if travel history. So risk factor is there, we should immediately go for a CTPA rather than just doing a D-dimer. Okay. Even though they are asking next investigation, this is one of the cause or one of the condition in which we do CTPA mainly. In pulmonary embolism, if you think it's pulmonary embolism, you do CTPA. Okay. Unless the patient is very low risk, then you can do a D-dimer. Even D-dimer is not a specific because it can be positive in a lot of other conditions. We will discuss more about this D-dimer, CTPA, and pulmonary embolism in our respiratory class. Okay. 60 years old male, 10 years history of hypertension, feeling dizzy, lightheadedness from this morning when he was doing exercise. Smoked 20 cigarettes per day. So he's a smoker. 2 to 3 glasses of wine most of the night. Blood pressure, not bad. And seating. So seating is 138 by 80. And lying is 120 by 75. A little bit of postural hypertension. Currently on irbesartan thiazide and aspirin. And if you look at here, it's a high dose. Symptoms lasted for about 2 hours. ECG given, which shows SVT, heart rate about 150. What is the cause of this presentation? So it's a confusing question, I would say. So patient is a 60-year-old feeling dizzy and patient having lightheadedness since this morning. The only thing that is missing in here that there is no chest pain. If it was a chest pain case, I would immediately think about ischemic heart disease. Or even if this patient was diabetic, then it could be a silent MI. Then we don't need to even think about chest pain, right? So we could think about ischemic heart disease because that's the most important thing to rule out in this patient. But there is no ECG finding, no chest pain, so unlikely. Hypertension, it can be a cause, but again, not the very promising one. Alcoholic cardiomyopathy, Alcoholic cardiomyopathy, unlikely for someone who is just drinking two to three glass. Like 2 to 3 glass of wine doesn't cause alcoholic cardiomyopathy. Okay. It should be like a massive amount of wine he should take to make it cardiomyopathy induced by alcohol. So most likely reason, if they are asking, now two type of question can come. They can say, what is the most likely cause of his presentation? It's dehydration. Why? Because he was doing exercise, then all these symptoms started. So exercise can cause dehydration. Okay. And on the top of that, this patient is on 2 volume depleting drug, irbesartan, which is your ARB, and diuretics, and high dose diuretics. So that can also result in this like excessive dehydration in this patient. Okay. So not only this drug, because this patient was on this drug for a long time, why previously it did not cause it? That's the question. But on the top of this drug, he's doing exercise. Maybe this exercise has triggered this SVT. And if you look at one of the Australian, you will find out that physical activity or exertion can induce SVT in these patients. Let's have a look. See, episodes of SVT may be triggered by factors including caffeine and alcohol, bending over, sudden movement, stress, physical exertion, and fatigue. So physical exertion sometimes can trigger episodes of SVT. So that's most likely reason in my view in this patient. But again, look for some other things, like if this patient is diabetic, we would think about IST in this case, because for someone who is 60 years, that's one of the important things. If in the question then they ask that what is the most important cause you want to rule out, or what is the most important cause you want to exclude in this patient, that should be ischemic heart disease. Okay, but if they ask what is the most likely cause, that's most likely dehydration. Next, ECG with a bradycardia and a prolonged QT syndrome. Patient came with chest pain for 15 minutes and relieved by rest. Troponin normal, pulse normal, regular, BP normal. What to do next? Repeat troponin, echo, coronary angiogram, repeat ECG. So remember what is the time duration of stable angina? 5 to 10 minutes. Anything more than 10 minutes, you think about something is not good. So this patient had a chest pain for 15 minutes. And let's say it's a 55-year-old man. So elderly or middle-aged patient, you can say high risk. For this patient, if they have chest pain, even if it is resolved or relieved by rest, you can't just send them home with a 1 ECG and troponin. You have to do the repeat one. So which one you want to repeat first? Repeat troponin or repeat ECG? Repeat ECG first. Okay, you don't just repeat troponin first, because normally you do repeat. Now, obviously, we do both repeat ECG and troponin in this patient. If we need to choose between 1 and 4, troponin and ECG, obviously before troponin, ECG should come. Because what we can get in the ECG, we might get some changes, right? So we did after 15 minutes of chest pain, 1 ECG. Now maybe after 4 hours, if we do another one, we might get like a totally another ECG. So this ECG change is important. Normally we do repeat ECG in 4 hours. Same troponin also after 4 hours. A woman on multiple drugs, one of them was digoxin. She presented with central abdominal pain and tenderness. Her pulse was irregular. Apart from CT, what is the most appropriate next investigation? Now, I understand we haven't discussed about it, but somehow it is related with cardiology, although the patient presenting with central abdominal pain. Any patient having irregular pulse, we think about atrial fibrillation immediately. Atrial fibrillation, it is very notorious to cause clot. Okay, so atrial fibrillation can cause clot, and from that clot, one of the emboli can be dislodged, and it can enter into the superior mesenteric artery, causing the blockage of gut arterial supply. And what we call that? Mesenteric ischemia. And mesenteric ischemia comes with central abdominal pain and tenderness. Okay, so that's the complication of AF. So AF patient having central abdominal pain and tenderness, especially elderly patient above 60, we should always think about mesenteric ischemia. So what is the next investigation for someone who you are suspecting mesenteric ischemia? Next, abdominal ultrasound, lipase, lactate, digoxin level or digoxin level. So initially we choose serum lactate, guys. Okay, not abdominal ultrasound. Abdominal ultrasound cannot show mesenteric infarction. If you want to confirm it, you have to do a CT angiogram, because abdominal ultrasound is not that much sophisticated to get mesenteric ischemia. Very unlikely you will get anything on abdominal ultrasound. Okay, because mesenteric artery is blocked. If one of the artery is blocked, okay, that part of the gut is not getting blood supply. And what will happen? Initially, there will be lack of oxygen supply in those areas. It will start dying. And then anaerobic, like normally what will happen? There will be infarction in this area, right? When there is infarction, you will get increased lactic acid production in here. Okay, so that's why normally we do a serum lactate initially in suspected mesenteric infarction. Okay, so any time you get somewhere there is infarction or a limited amount of oxygen supply, in that tissue, anaerobic glycolysis starts. And the end product is this glycolysis will turn glucose into lactate. And if you measure the serum lactic acid, you will get it high. Okay. So this is central abdominal pain in mesenteric ischemia. We'll discuss it in detail in abdominal pain or in GIT. Okay, I guess again this. Right, no worries. Let's just discuss this one. So a 23-year-old man comes for follow-up. His bilateral blood pressure, bilateral arm BP is 140 to 60 by 100 to 110 on several occasions. That means this patient is hypertensive. Occasional headaches, rest of the physical examination and urine analysis is normal. Heart rate is good with mild left ventricular hypertrophy. Patient is using beta blocker, thiazides, captopril or ramipril, okay, ACE inhibitors. Blood pressure is high, as you can see at the moment. What is the next appropriate step? The only thing which will let you think about renal artery stenosis is this refractory hypertension this patient has got. Look at the blood pressure medication. He is on beta blocker. He is on hydrochlorothiazide. He is on captopril. So 3 blood pressure medication. Still patient's blood pressure is 150 by 100. So that's a refractory hypertension. And refractory hypertension in a 23-year-old gentleman, it's not, most likely it's not something primary. Something is causing this thing. Okay, if we look at renal artery stenosis, should be considered as a cause of high blood pressure in people who are, 1, older than 50, who develop high blood pressure or have a marked increase in blood pressure, have no family history of high blood pressure, cannot be successfully treated with at least 3 or more different type of blood pressure medication. This is our patient. So if you are trying to if you're trying to use 3 drug in their maximum dose, still someone blood pressure is not controlled, you should always look for this sort of secondary hypertension cause. Okay, so look for renal artery stenosis because young patient most likely tends to get renal artery stenosis. Okay, so what do you want to do? You want to do a duplex ultrasound of the renal arteries in here. Elderly man taking digoxin and hydrochlorothiazide presents with palpitation and ECG is given. What is the cause of his problem? Let's look at the ECG. You might not understand it, but that's fine. So what we have got, elderly patient on digoxin and hydrochlorothiazide having palpitations. ECG is given. Now, to be honest, to get this question answer, we need to have a very good idea on ECG. So let's not waste a lot of time on this question, but I'll just show you very quickly what's the most likely reason in here. It's a digoxin toxicity case. Why we know that is that if you look at digoxin toxicity ECG, you will get a reverse tick sign like this. See this line in here? This one, this one. This is called reverse tick sign. Okay, if you get something like that in a patient, we should always think about digoxin toxicity. We'll get to know about these toxicity features more in the ECG class. Okay, so let's just keep it as a digoxin toxicity. Why not is hypo or hyperkalemia? Again, we need ECG features of hypo and hyperkalemia. We will discuss that. Don't worry. Next question, patient on many medication, metoprolol, digoxin, furosemide, ECG given, patient complains nausea, vomiting, abdominal pain. Digoxin level given, but it is normal. What to do? If we look at this ECG, what we can find out? Let's see. Can we find out anything in here? Again, you have to know a little bit idea about ECG. Let me just show you what is the finding in here. This is called first degree heart block. Okay, prolonged PR interval. So first degree heart block, any heart block can be caused by digoxin toxicity. And if you look at here, nausea, vomiting, abdominal pain, these are the most common feature of digoxin toxicity. But digoxin level is normal. Yes, even if in the blood digoxin level is normal, sometimes it can cause toxicity as well. It depends on the symptom and ECG finding. So in that case, what you want to do, you should immediately cease digoxin to this patient because it's involving the heart. Okay, so cease digoxin is the first thing that you do. And first degree heart block usually gets better if you just remove the offending agent. Again, one of the other ECG finding of Wpw syndrome is done. So Wpw syndrome is a condition in which you will get an aberrant accessory pathway. Now let's discuss it a little bit so that we don't need to discuss a lot in our ECG class. So what happens in the heart is your electrical impulse start from SA node in here, goes to the AV node, and then it transmits throughout the ventricle through this Purkinje fiber, bundle of His, etc. So this AV node, it's one of the main function is if there is any increased arrhythmia occurs in your atrium, this AV node is supposed to block that. It will not, or it will prevent any increased arrhythmia or impulse to travel to the ventricle. Okay, so this is a normal natural phenomenon. Now, in Wpw syndrome, what happens? There will be a formation of accessory pathway which will bypass this AV node. So, if there is any arrhythmia starts in the atrium, it will directly go to the ventricle, and it can be like seriously problematic. Like you can see the heart rate 280. So something like that, because AV node is not functioning in here. Now, in the treatment, again, if this patient is unstable, this patient's systolic blood pressure is good, 105. So nothing problem. So you don't need to go for any DC cardioversion. If it is an unstable patient, we go for DC cardioversion. Same like SVT or AF. Now that we know this is a stable patient, medical management will be our choice. Remember, we can't give any medication in Wpw syndrome patients which can reduce the heart rate. So what can cause reduction of heart rate? Especially what can block AV node, or that's the thing, okay? So we cannot give any medications which will block AV node or which will ultimately reduce heart rate. Okay, that means rate limiting, nothing we will give. So we don't give calcium channel blocker. So we have to avoid CCB. We have to avoid beta blocker. We have to avoid adenosine. We have to avoid digoxin. So all of this can make it worse. So no digoxin, no adenosine, no rate limiting calcium channel blocker. This patient is stable, no DC cardioversion. Only medication that you give is the antiarrhythmic agents, because that doesn't work on this AV node. Okay, very, very important question, comes in frequently in exam. So please keep it in mind. Amiodarone is the best option for someone who is having Wpw syndrome. And we'll discuss the ECG finding of Wpw syndrome. You will understand it very clearly. Next, a 65-year-old patient presents with lightheadedness and palpitation. Examination was clinically normal. He is on perindopril, L-troxin, verapamil, anti-diabetic medications, ECG showing first-degree heart block. What is your next appropriate treatment? So what do you think you want to give to this patient, or what do you want to do? So L-troxin is thyroxine, okay? So you want to increase L-troxin, stop verapamil, stop perindopril, add digoxin. It's given already. So you got ECG and you got first-degree heart block. We don't give any rate-limiting medications in someone who is having heart block. And that's the management also. Always stop the drug which can reduce the heart rate in a heart block patient. On the top of that, this patient is having lightheadedness, palpitations also. So what you want to do is stop verapamil in this patient. A child with upper respiratory tract infection treated for infective endocarditis. Blood culture has been taken, treated with penicillin, but still murmur persists. What to do? Now, infective endocarditis is a whole other entity. Usually, we might discuss in infectious disease classes. But remember one thing, in infective endocarditis, which means there is an infection, or you can say it's a vegetation on the heart valve or endocardium. If you start antibiotic, the murmur should get better. If still murmur persists, we should think about maybe some new vegetation, or the vegetation is still there. So you need to confirm it by doing an echocardiogram. So only by doing an echocardiogram, you can say that this patient is not having any more new vegetation, or the previous vegetation has been treated. Because they say that it has been already treated with penicillin. So you should not get murmur in this patient. Okay. So you need to do an echocardiogram in this patient immediately. Because doing a repeat blood culture will not work, because this patient is not having any symptoms rather than murmur. Give antibiotic for 4 weeks with blood culture weekly. They already say that it has been treated with penicillin, so we don't need to give this one again. The most important thing is that we need to do a repeat echo just to make sure there is no vegetation left. A pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. X-ray shows bivasal effusion and cardiomegaly, and you get bivascular crepitation in the lung. What is your next appropriate investigation? What's your diagnosis, by the way? Pregnant women having dyspnea, orthopnea, having cardiomegaly, basal crepitation, so CCF, right? So for CCF, what is your next appropriate investigation? ECG, echo, D-dimer, CTPA. Guys, remember the next appropriate investigation. Did you guys forget about what we discussed? ECG. Always start with ECG, okay? Because this patient might have myocardial infarction or ISD causing this heart failure, right? You don't know that. And also remember, if they're asking next investigation, you should never ever start with the echocardiogram. You should obviously do a ECG first, okay? So always think that, guys, if they would ask you what is the most appropriate investigation, then you would choose echo. All right. Don't forget that, guys. It's a very important questions, and people, like, without even thinking, they choose echo, and they know that AMC knows about those sort of things. Okay, so don't do this sort of mistake in the exam. Now that you at least know about it. Pacemaker syndrome with difficulty in breathing, with faint heart sound. So actually, what happened in here? You inserted pacemaker in a patient, and patient started to have this shortness of breath or difficulty in breathing, and there is faint heart sound. SpO2 saturation is okay, blood pressure 90/60 not good, so hypotension. JVP is elevated with no ECG given. What is the investigation of choice? If you remember our previous class, you will know what is this. Remember the Beck's triad? Muffled heart sound, hypotension, and raised GVP. What's your diagnosis? Pericardial effusion, or even it could be a cardiac tamponade. What is your investigation of choice for this patient? Now you don't need to do ECG because they're asking investigation of choice. So you do an echocardiogram. Okay, so it's very important in this case, because it's most likely going for a pericardial effusion or even a cardiac tamponade. So we need to do an echocardiogram in this patient. Next, a hypertensive and a diabetic patient presented with history of numbness. Let's say this patient is 55-year-old man. Okay, so hypertensive diabetic, history of numbness, nausea, and sweating. He developed dizziness while urinating, pulse irregular. That means he's also AF patient. ECG shows that. What is the diagnosis? Myocardial infarction, micturition syncope, Vpw Syndrome. Now, don't just fall into the trap. That's the thing. 55-year-old having dizziness, nausea, sweating, okay, on the background of hypertension, diabetes, you don't just think that this is a micturition syncope, right? Like he just went for urination and he developed a micturition syncope. No, there might have underlying MI in this patient. And remember, the most common cause of AF, like about 15% cases, ISD is the cause of atrial fibrillation. So this is a diabetic patient, right? So it could be a silent MI. Very good. So always remember it, guys. Everything given in here is a clue. And you see this nausea, sweating. This is also a presentation of myocardial infarction. So any patient who is hypertensive, diabetic, you need to think more than what is given in here. Okay, and this is a common trap. Most of the candidate, when they will see that, they will think that it's a micturition syncope. Okay, so we need to think a lot when we are choosing an answer in the exam. And micturition syncope is very uncommon, not very common also. Okay, next question. Elderly patient brought after fall. She is confused and she is on warfarin. Very important. Warfarin is a blood thinner. So having a fall on a patient who is on warfarin, it's not a good idea. Bruises on both thighs and buttocks. Troponin is okay. CK, you can see the CK is very high. So normally 60 to 220. So CK very high on a patient who is having bruises on the both thigh and buttocks after a fall. What you should think about? Recent MI less than 12 hours, MI in 4 hours, rhabdomyolysis. Now, if troponin is normal, you don't think about MI. Like if it is a MI in 4 hours, troponin should be increased because in 4 hours, troponin usually gets increased. Same with 12 hours. So this is a case of rhabdomyolysis. Let's have a look what it is. So rhabdomyolysis can occur in elderly patient if someone like have a fall and they were confused. Maybe they were confused for a long time. Okay, and because of that, sometimes rhabdomyolysis can happen. Let's discuss about it a little bit. So what is rhabdomyolysis? It's a condition in which there is muscle breakdown followed by necrosis occurs. Because of muscle breakdown, the intracellular content of the cell comes into the circulation and it can cause a lot of other complications, especially it can cause compartment syndrome and acute kidney failure also. Usually occurs sometimes after trauma, crash injury, sometimes having a fall and being confused and left on the ground for a long time. These are very commonly can occur. When muscle injury causes intracellular content to be released into the blood, it can release potassium, myoglobin, uric acid, and also creatinine kinase, ALT, AST, everything can get released. Okay, and because of that, myoglobin sometimes also can be precipitated in the kidney and can cause tubular obstruction, followed by acute kidney injury can happen. Very important. So the classic triad is muscle pain, muscle weakness and swelling, and a tea-colored urine, which is for myoglobin. The lab, you will get a very high serum creatinine kinase. You can get kidney failure feature. So urea creatinine will be high, myoglobin will be high, potassium will be high. Okay, so these are important. In the urine dipstick, you can get myoglobin urea also. Diagnostic criteria is elevated serum CK. The main management for rhabdomyolysis is rehydrate the patient because you need to treat or prevent acute kidney injury. Okay, and because dehydration usually happens after this muscle necrosis and everything, fluid hydration is the first thing that you do. These are the complications of rhabdomyolysis, hypovolemia. So that's why you give rehydration by normal saline, hyperkalemia, hypocalcemia, cardiac arrhythmia, cardiac arrest. And eventually patient can get kidney failure also. Okay, so this is the rhabdomyolysis in our patient. See, muscle tissue breakdown with release of intracellular content into the circulation. Patient develop muscle pain and weakness. Okay, myoglobin can occlude kidney tubules and can cause tubular necrosis or acute kidney failure. Because when myoglobin is kind of reddish, you can get a tea-colored urine. Next, a patient on medications for hypertension, which is perindopril and indapamide, she feels dizzy when getting out of the bed. Happening for a while, she also had some falls. Blood pressure 160 by 100, having atrial fibrillation. What is your next investigation? Any elderly patient getting a fall and usually occurring after getting out of the bed, you should always consider the possibility of postural hypertension. Always. Okay, getting out of the bed, that means they were sitting or lying, and when they stand, they get this dizziness. And that's called postural hypertension or orthostatic hypertension. Now, this BP 160 by 100, it hasn't told you that is it a standing or sitting BP. So this is the clue in here. So you want to do a echo, X-ray, Holter, 24-hour BP monitoring, or repeat for postural BP measuring. So always we need to do a repeat postural BP measurement in this case. Okay, 24-hour BP monitoring is not needed at the moment because it's indicated if someone having a discrepancy between office BP and home BP. Okay, but this patient having postural hypertension, you need to confirm that by doing a repeat postural blood pressure measurement. So you do blood pressure measurement in a standing position and then, first sitting position and then a standing position. And then again, you confirm it by doing a repeat one. Okay, so that's the most likely reason in this patient. Any questions so far, guys? A 70-year-old man on Ramipril 5 milligram for hypertension. On examination, blood pressure is 150/90, so it's not well controlled, as you can see. Pulse normal, cholesterol is high, 6.5. Rest investigation within normal limit. Which one of the following will reduce the risk of his stroke? Low dose aspirin, clopidogrel, increased ramipril, atorvastatin. What do you think? 70-year-old, reduction of risk of stroke. For this patient, it would be a good idea. Now, two things is a possibility in here. If they would ask you that which one will reduce the risk of myocardial infarction, you would choose low dose aspirin. Okay, we should obviously give aspirin in this patient also. If they would ask you which one will reduce the risk of having an ischemic stroke, statin would be the best option also. If they ask you which one is best to reduce the risk of hemorrhagic stroke, that would be increasing the ramipril, because hypertension is the most important cause for hemorrhagic stroke. So depending on what they actually ask in the question, we need to choose accordingly. Okay, but among everything, the most important part is hypertension. Remember that, guys. Like cholesterol 6.5 may not kill the patient, but hypertension in a 70-year-old, we should always consider lowering it down. Because this patient, if you look, remember the CVD risk factor, the 5-yearly CVD risk factor. If we put this patient, any patient who is above 60, already they become high risk 5-yearly cardiovascular risk patient. So even you don't need to think about like what is the risk of this patient. So this patient is already high risk. For someone who is a high risk, maintaining their blood pressure is the most important part. Okay, even though everything is important apart from clopid in this patient, so we should give aspirin in this patient, we should give statin in this patient, but the most important part is to making sure this patient blood pressure is well controlled. Nothing is important rather than improving the blood pressure in this patient. Okay, so always remember, like these sort of questions are very complicated. Okay, looking at the question, it doesn't look like that, but sometimes many candidate, even by just looking at the cholesterol value, they would think about that, well, it's a very high amount of cholesterol, let's give statin. Obviously, we should give statin in this patient. Okay, even if this patient's cholesterol was 4, I would give a statin because he's a high risk patient. But the question is, which one will reduce his risk of a stroke mostly? Something like that would be there. So that should always come into the hypertension. We should always control hypertension no matter what. And for this patient, 150/90 is like super high. So a 57-year-old man complaining of anorexia and weakness, known case of CCF on digoxin 0.25, furosemide hydrochlorothiazide, lab value CBC normal, sodium 131, potassium 3.1, atrial rate 180, ventricular rate 110. What's your management? Okay. So we have got anorexia and weakness in a patient who is a known case of CCF on digoxin, and also other medication. Sodium, potassium is a little low, as you can see in here, because it could be furosemide hydrochlorothiazide causing it. Atrial rate 180, ventricular rate 110. Obviously tachycardia in this case also. So what do you want to do? You want to increase furosemide hydrochlorothiazide. So increase hydrochlorothiazide should be the option. Stop digoxin and add potassium. Defibrillator or cardioverter. If we just give you some option, then you would understand. Oh. Let's just keep it like that. So what do you want to do in this patient? You should stop digoxin in this patient because digoxin can cause this arrhythmia this patient having. On the top of that, he's having already the features of digoxin toxicity, anorexia, weakness. And not only that, this patient is on furosemide and hydrochlorothiazide causing hypokalemia. Okay, this patient should have a stop digoxin and adding potassium. See that in the question, everything is given. You just need to understand what they're trying to say, right? Aboriginal lady has mitral stenosis and dyspnea. Very important that someone is Aboriginal. We should think about something more important thing. And not only always we think about it, sometimes it could be a trap also. Mitral stenosis and dyspnea. On chest auscultation, there is bilateral basal crepitation. No fever, cough, or sputum. Chest X-ray given with bilateral perihilar opacities and asking for diagnosis. Let's say this is your chest X-ray given. So what you can see bilateral perihilar opacities. In a patient who is mitral stenosis patient having dyspnea and bilateral basal crepitation. Do you think anything else apart from left ventricular failure? No, you should not think about anything apart from left ventricular failure. Now, sarcoidosis can also cause bilateral perihilar opacities. It doesn't cause bilateral perihilar opacities like that, like this patient. It causes perihilar lymphadenopathy. It should be something like that. It should not be like batwing appearance, as you can see. Not only that, this patient, if it was a case of sarcoidosis, patient would have cough, okay, some other features, and not bilateral basal crepitation also. So don't think about sarcoidosis at the moment. And you can say a lot of other other thing. But again, think about how we can rule that out. Let's have a look. The sarcoidosis is unlikely because this patient is having bilateral basal crepes, no cough, X-ray doesn't go with it. X-ray should be, like when we'll be doing the respiratory system, we'll discuss it. So this should be something like that. So it's the hilar lymphadenopathy. If it was a tuberculosis, it can cause any lung finding in a TB patient, but TB patient doesn't have fever, doesn't have cough, very unlikely, right? And obviously they would give you some history of like traveling into Asian countries or endemic countries. Pulmonary hypertension. Pulmonary hypertension doesn't give bilateral basal crepitation, okay? And also the X-ray finding that you can see, it's not a pulmonary hypertension X-ray finding. Let me show you how pulmonary hypertension looks like. This is what it looks like. So you will get something like that. Okay. So normally this is the shadow you can see. It's a raised or enlarged pulmonary artery shadow. What you can see just like that. It should not give a batwing appearance in pulmonary hypertension. And not only that, pulmonary hypertension doesn't cause bibasal crepitation. Okay. So this patient having rheumatic heart disease, and rheumatic heart disease is getting complicated with a left ventricular failure. Now, question changes a lot. If this patient having fever, low-grade fever, cough, we should think about tuberculosis. Low-grade fever, cough, okay? Any X-ray findings. In tuberculosis, X-ray can be like, you can get opacities in anywhere in the lung, especially in the top part, apical part. You can get cavitation. You can get air fluid level, abscess, as I'm saying. So lots of finding you can get. You can get miliary TB, something smaller like this. So all of the finding can be there. So according to what they give to you in the exam, any of these option can be a possibility. But for this question, you don't think about pulmonary hypertension or TB. Okay, this is our last questions, and you guys are going to answer it. Lady 75 years old, having hypertension, diabetes, well controlled on drugs. She has an episode of chesting for 15 minutes, which is relieved after rest. Medications are ramipril, metformin, metoprolol. Blood pressure is good, heart rate is little low. Which of the following investigation will you consider next? 75-year-old, having chest pain during walking, so exertional chest pain for 15 minutes, which is relieved after rest. So you want to do a troponin, thallium scan, Holter, CT angiogram. Troponin, guys, nothing else. We don't think anything. So troponin should be done in this patient because 75, hypertensive, diabetic, okay, having a chest pain which is more than 10 minutes. Even though at the moment patient is totally fine, we should always rule out MI or any form of ischemic heart disease in this patient. All right, so this will be our finishing tonight. Do you guys have any question in your mind? Anything that you haven't understood today? Those who are in the Facebook, I can see this is a very small amount of you are in the Facebook. So please come to Zoom from the next sessions so that we can answer your queries also. All right, so I hope you guys are enjoying the sessions. And that's the most important part, right? So if you guys like the class, we are happy. So next class, you should get the next class schedule in the Facebook, I think. Let me have a look. I always forget these schedule things. There is another class, as I can see, on 12th of September on a question solvation, right? So 12th September will be our last session. Drug interaction, Dr. Janathan, there is nowhere you can read it. Unfortunately, when you will be like reading a theory, you should also go through the medications. Like usually in Kaplan step 2, they have a very good discussion on those medications. So just read the Kaplan step 2 during that time. Only the important drugs like ramipril, like ACE inhibitor, ARBs, diuretics, those are important. So you will know what are the important drugs, and they usually stick to that. You can also check the drug-drug interaction from the eMedicine drug checker. Okay, so eMedicine has a something software like that. If you put two medication, it will show you all the interaction. I think it's known as eMedicine drug interaction checker. So if you guys are having any questions about the course, feel free to ask me now or maybe on our last session on 12th of September. The last class will be the 12th September, and remember that our admission will be closed from 15th of September. So any of you interested to join, feel free to contact us or send us an email. Okay, we'll be happy to help. Thank you all for joining the sessions. I hope you enjoy. Have a good night. Bye.